if you look at the shift again, primary outcome, MRS at 90 days, it favors endovascular thrombectomy across the groups, whether it's an ICO occlusion, whether there's more than 33% MC involvement, whether there's an aspects of 0 to 4. So more than 1/3 they have classified according to this Atlantis worksheet, that you identify the areas of frontal, parietal, temporal, basal ganglia and insular cortex, and if you have substantial infarct in more than 2, then it's a more than 1/3 MCA territory involvement. If you bifurcate it further into aspects 0 to 2, 3, 4, 5, except for aspects 0 to 2, which practically means the whole of brain has already gone, there's still data to suggest doing endovascular treatment, patient do better rather than medical management. So except for aspects 0 to 2, all other aspects group, they recommend treatment. And there is no increase in mortality, though there is increase in symptomatic hemorrhage in these patients when you do it in more than 1/3 MCA territory or aspects of 0 to 2. But so more hemorrhage, but no change in mortality. And these are independent predictive factors. There's one more meta-analysis of 7 institutional registries, which are more of real-time data which you can get of aspects 0 to 5. And again, they find that the benefit is there without significant increase in the hemorrhage or mortality. And which is again across the spectrum, no change in mortality and ICH. MRS 0 to 3 or MRS 0 to 2, both are equally achieved. The key again is to get TICI 2B or 3 recanalization. Just doing mechanical thrombectomy is not going to help the patients. So these are the change in guidelines which happened through SNIS. So they said, if you do have low aspects or a high volume core, you still can do mechanical thrombectomy, though the level is 2A. Okay. So it might benefit. And as I was saying, if you do not have perfusion, for first 6 hours, the guideline now says you don't need to do perfusion imaging. You can just do CT scan or MRI and make sure there's a large vessel occlusion on an angiogram, and you can straight away take these patients if the aspects is more than 6. We sort of do the other way because, once in a while we see these patients. This patient, window period of 4 hours, if you look at the aspect score, I do not have the complete CT, but it's like 7-ish. So it can be 6, 7 or 8. But eventually on a large vessel occlusion, when you do a perfusion scan, you find that the mismatch is really not there. Now, I can go back and argue that, still we have to do it because even in low aspects it works. But somehow we still are on a conservative side, but that's the evidence which is coming in, that you can skip all this and just do a plain CT angiography and take these patients. We particularly like to do perfusion because we believe aspects is not a linear scale. It's there in all the publications, but it doesn't take into account eloquence, it doesn't take into account the difference rate by which gray matter and white matter infarcts. It doesn't take into account that there is no dichotomized thing. It's either infarcted or not infarcted. There is a process. There is decrease in ADC values over a period of time. All that is not captured by aspects. And sometimes, these patchy infarcts which you see on MR diffusion and your aspects drop down significantly. But, in reality, these are patchy infarcts. And if you open up these arteries, there's a good chance that these patients will have a good follow-up scans. So aspects in isolation, again, you have to take it with a pinch of salt. So between 6 to 24 hours window, the trial says, the data says, we have to follow the rapid software diffusion protocols and select the patients as we have seen before. But now again, what to do when you have a confusion between diffuse and dawn? So diffuse takes larger infarct volumes up to 70, while for dawn, depending on the age, it can be 20 or 30. The lower NHS is with diffuse. For dawn, the limit is 10 and above. So what do you do when you get a patient like this who has got an NHS of 8, window period of 8 hours, a small core, big penumbra, and a large vessel occlusion? Do you take these patients to mechanical thrombectomy and say, oh, it doesn't fit the dawn criteria, the NHS is less than 10, but it fits the diffuse criteria. So am I going to follow the diffuse criteria? Am I going to follow the Dawn criteria? So that's a question. So we did decide to take it because we thought NHS is again a subjective thing. So we open up the artery. The ICA we couldn't open up, but there were good collaterals, and this patient had a good follow-up scan in 12 hours. And that was the data from diffuse, that if you look at the data, the patients who were ineligible for Dawn trial in diffuse, they also had a better outcome. So the criteria for ineligibility can be, change of baseline NH score, as we saw with our patient. It could be age, it could be a baseline volume. So it's there for trial, but in real world, probably it still works if there is a good penumbra. The other point of differentiation is carotid stenting. Dawn does not permit you to do carotid stenting. In diffuse, carotid stenting is allowed. Whether it's good or bad, we don't know. I'll show you an example. We have burned our hands. So in this patient, we decided to take this patient up because there was a good penumbra. It fits all the criteria. The ICA was closed. We tried plasty, couldn't do it. We had to place a stent, open up the artery, but then we had a major hemorrhage. So we sort of shy away from doing carotid stenting now in these late window period, but you have a diffuse trial data to back you up. So these are the guidelines which are saying that, even if the patients do not fit exactly into the criteria of Dawn and diffuse, you still have a level 2B evidence to go in and do mechanical thrombectomy in these patients. And so these are data from a White Registry of 126 patients, which is getting MRS 0 to 2 in around 46.7%, approaching the Dawn, sort of 49% of Dawn. So it's the real world data published before Dawn, and this is the new data again from the same authors, Tudor group only, who published the Dawn trial, and they said that patients who were ineligible, they also had a 30% better functional independent outcome despite not following their own trial inclusion criteria. So the number from Dawn inclusive, diffuse, it's not coming up nicely, but it really doesn't matter. So you still get the benefit. So you need to carefully select your patient. There has to be a perfusion mismatch, a large vessel occlusion, and you open up the artery, and these patients tend to do well. What about stroke severity? So in stroke severity, as we said, NHS of more than 6 is acceptable. NHS of less than 6, you have to look for the disabling symptoms, which in anterior circulation predominantly is speech. So if we get a patient like this who has only aphasia and a motor drift, low NHS, but on perfusion we see that there's already an infarct in the speech area, we can't change much there. Good collaterals, the MCA is open, the ICA is closed, we tend not to treat these patients and wait. Or patients with a large vessel occlusion but very good collaterals, NHS of 3, we still tend to wait, follow-up scans, or rapidly improving patients. Sometimes we bring these patients to the lab, but by the time we are draping them, they start to improve, and we know that there's a large vessel occlusion, but since the patient is improving, we do not treat. We only tend to treat when there's a disabling speech issues, like in this young patient of 21-year-old who had an expressive aphasia. On perfusion scans, we can clearly see there is a penumbra around the speech area. The vessel is occluded, so we will go ahead and open up these arteries in selected number of patients. I think there are one of 2 examples which we'll see. What about location of large vessel occlusion? So we have level 1A evidence to say M1, we have level 2B evidence to say M2 and M3, and beyond that ACA vertebral basilar, we again have 2B evidence to open up these arteries. The clot burden, we know that, if there's a higher clot burden, these patients will benefit more with treatment rather than with medical management. So M2 is very controversial in endovascular arms because most of the trials have not included them. The number was small, and it's so funny that even the endovascular people don't know what actually constitutes M1 and M2. So M1 and M2 is not the bifurcation, it's the point where the MCA turns superiorly into the Sylvian fissure. And the retrospective analysis of few of the patients, of these trial data patients, found that they were mistakenly labeled as M2 when they were M1. So, which led to this paper by Dr. Goel and saying what really constitute M1 segment of MCA. So the guidelines now say, you can safely treat them till M1 and M2. Beyond M2, you have to take a call based on individualized patients, especially for anterior cerebral artery and posterior circulation. So one such patient of anterior cerebral artery patient had just the right lower limb weakness with good perfusion, and he was an auto driver, just the breadwinner for the family. We talked to him, decided to go ahead and open up this artery. So we have these mini catch retrievers and mini stent retrievers which we can use in these conditions, and of course when I'm showing you, these patients have done well. So I'll just skip for the time interest. It's the same thing, speech area. We will do it because this speech area is involved, and we talk to these patients and explain the risk which is there, because they are like borderline guideline patients. We do not have conclusive evidence for these. For posterior circulation, there are no randomized controlled trials for obvious reasons. 24 hours is actually the window. We do an aspect score, giving 2 points for midbrain, 2 points for pons, 1 each for thalamus, occipital cortex, and cerebral hemispheres. Anything less than 7, the patients do not do well. And this can be done on CT perfusion or MRI, ideally an MRI. So you do this. If there's an artery occlusion, the principle remains the same. You go ahead and open these arteries. So I'll just skip this part. And of course, this is actually the more common scenario that you see when these patients, they come up, they are even M1, fixed dilated pupil, everything is usually gone. We do not intervene when this is the situation. So coming to the last part, to the time again, who will benefit? Faster you do, better it is. And this is the large registry of 6,756 patients, a US-wide registry, which has shown that every 15-minute increment which you can do, either from onset to opening or from door to puncture, these patients have a better chance of getting discharged and ambulatory. And this is across the spectrum, discharge times and survival and functional independence. And this was also shown in DAWN that, despite the long time period window, the patients who came early did better than the patients who came late. So some part of it will depend on the interventionist who is doing it, like how many passes he is doing to take the clot out, what is the revascularization time, and of course as the time increases, as the number of passes increases, the outcome becomes difficult and different. But what other factor is there which we actually do not talk about in literature is where your interventionists stay in relation to the hospital. So if I stay in Gurgaon and I'm working in Apollo, if I have to spend an hour on the road, it doesn't work out. So me and my colleague, we are like 10 minutes away from the hospital, and the fellow actually has to stay right next to the hospital so that they can be in there. So that is something which has to be considered. I was trying to find an article somewhere, but I couldn't. If you have some article, let me know. But I think this also is very important in Indian's context. The last part is randomness, chance. 2 patients to show that. So this patient who came to us, there is a mismatch on perfusion, but the CT angiogram actually looks normal. So we were looking at it and there has to be somewhere something, because the patient has a perfusion mismatch. He's clinically symptomatic, but there's no occlusion. So we took him up for angiogram. There was such good collaterals that the MCS seems to be filling on CT angiogram. So the patient actually had an M1, M2 junction block, but because of a good collaterals, we were not seeing it. So of course we opened it up, and then the patient had an immediate drop from NHS 9 to 1. Another patient with such kind of mismatch, NHS of 20, again big perfusion mismatch, but on CT angiogram again the MCA, ICA, everything looks okay. So we have learned our lesson, so we checked back and forth, we couldn't find anything. Patient got TPA, didn't improve, so we again decided to took this patient for DSA, and there was a carotid dissection which was extending into the petrous, which was hidden from the CT angiogram. So again, so it has to be a protocol thing. We rely a lot on perfusion imaging, And so this patient, eventually we put multiple stents to open this thing up, and I'll skip this part. So take home message, from 6 to 24 hours, large vessel occlusion, good penumbra, high NHS score, go ahead and open these arteries. Up to 6 hours, large vessel occlusion, aspects of more than 6, NHS of more than 6, some benefit in low aspects and low NHS score, and distal vessel occlusion also. Thank you so much.